Hello, everybody. Good afternoon. Welcome to this webinar hosted by the National Resource Center on Nutrition and Aging. This research center was established 6 years ago with grants from the Administration for Community Living. There's a lot of information and resources for senior nutrition professionals, and I encourage you to visit the website at http://nutritionandaging.org, and we'll put that in the reminder email also. Do visit the center because we have so many valuable resources for you. So my name is Magda Hegeman-Apel, and I'm the Vice President for Education and Training at Meals on Wheels America. And Meals on Wheels America hosts the National Resource Center. We're delighted to see that so many people that attended the webinar last year are returning visitors for this second webinar, where you'll hear from colleagues in the senior nutrition field who have been contracting with healthcare entities. And I'll introduce them to you in a second, but I wanted to remind you how you can communicate and engage with us. If you look at your screen on the right-hand side, you should have a box, a menu, and one of the menu options on there is questions. And so click on that, and then you'll see an option to send questions to the whole audience, to all participants, and then put your text in and do, ask questions, give us comments, etc. I'll be monitoring those throughout the webinar so we can get your questions answered. So I'm very thrilled to be introducing Karen to you again. For those of you who may not have participated last week, Karen is the Vice President of Nonprofit Impact, a mission-driven company that helps organizations achieve results towards mission and demonstrate impact. They're based in Denver, Colorado. She has served over 650 nonprofits and government agencies over the past 20 years, and she knows quite a bit about collaborations and partnerships. Then we have Jody Bella she's the Business Development Manager at Meals on Wheels of Northwest Indiana. Jody comes from a for-profit world where she served in several capacities within the marketing field. She was hired specifically to have her program branch out into healthcare, and with her knowledge of the for-profit world and of marketing, she has been very successful in marketing, social media, and communication, as well as sales activities, which is important in this field. Then we have Lisa Labanti from the Senior Services, who's a Senior Services Nutrition Director at New Opportunities, Inc. in Waterbury, Connecticut. She's been with our program for many years, and I was reading her bio and saw that she started volunteering for meal delivery with the Meals on Wheels program when she was 15 years old. So she really has a lifelong love for Meals on Wheels programs and services. She's very interested in innovation, improvement, and inventions, and that's been the driving force when she wanted to provide more services and bring in new funding streams to meet the growing needs of the seniors in her area in Connecticut. And Lisa has collaborated on this healthcare outreach with Maureen McCarthy. Maureen is a registered nurse and the CEO and founder of Care Transitions. That's a post-discharge care management service. Maureen understands all the ins and outs of the clinical reimbursement for long-term care, and she's authored a number of publications and a very big toolkit, which I thought was very interesting to see. And they'll give you their information, their contact information in one of the last slides. And if there's any questions, be sure to reach out to them. They'd be more than happy to respond. And with that, I'm handing it over to you, Karen.
Great. Thanks, Magda. Welcome, everyone. Thank you so much for coming here today for the webinar. You're here because either you're already actively engaging in partnerships with the healthcare system or you're considering it for one of these reasons. Perhaps it's to create a new revenue stream. Sometimes we might look to work with healthcare because they have a broader reach than we may in our senior nutrition program. They may have a much broader audience. Or somehow it's just about making more pie, not just a piece of the pie, but new collaborations are happening as healthcare reform happens, and there's just a lot of opportunity that's coming from these types of partnerships. But as we look at the next slide, we also know, if you could change slides for me, we know that sometimes these partnerships aren't all that they're cracked up to be. They look great maybe at first, but a lot of times you'll also hear stories like we didn't get enough referrals, or we didn't bring in as much money as we thought, or it took more time than we expected, and I'm sure you could add to this list. So if we look at the next slide, the reason that we have all of your presenters here today is because we want to meet these goals for you. We want you to have a time to learn from your peers and their partnership experiences. It's one thing to hear or think about these things. It's another to hear stories from the field and to really understand what it means as it's happening in a day-to-day sense. We also want to learn from those experiences, so especially how to anticipate or troubleshoot common challenges. One of the questions we ask the presenters is, sort of, what do you wish you knew then that you know now? So we can learn from those experiences. I also want to have you understand and be able to apply some best practices so you can take your partnerships wherever they are to the next level. So if we can look at the next slide, there's our presenters. We just heard about that. So our agenda slide is the next one. And I'm going to introduce just a couple of key concepts at the beginning, so just a couple minutes of that, and then we're going to go and hear from folks in these partnerships. And as we finish each story, we're going to sort of recap a little bit in the context of some of those best practices. And then at the end, the last 15, 20 minutes or so, we're going to have open for questions. And there are also slides about other useful tools and best practices that we have prepped so that we can reference them when certain questions come up. However, just in case we don't actually get into some of those, I want to point you to the handouts that are under your little handout tab. There are 4 different ones. The different tools and things I'm talking about, this is Karen, are under the NI webinar materials. And then our other speakers will tell you what those other handouts are. Those are some samples from some of their partnerships, some of the tools that they have as well. In the meantime, as we're going through this, again, we are going to have a good chunk of time for questions, but it won't be until the end. So I want to encourage you, as you are listening and thinking about these concepts and what they mean for you, add questions to the chat as you think of them. And then Magda will come and join us and ask those questions to the presenters to start to get them answered. Okay, so make sure to add your questions in. So if we could go 2 slides forward, we're going to look at these key concepts. And the first one is that, and we went through this in some depth in the webinar last week. So if you didn't get a chance and you're interested in this, that's a place to go into this more completely. But this was the framework we used to say, like, how do we make some good decisions about who to partner with if partnering is right for us right now? And it was about understanding the environment, understanding your own interests, and clarifying how it's going to affect your capacity. And I wanted to bring this up again because sometimes if we run into a challenge or some kind of issue around our partnership, sometimes you got to go back to the beginning and look at some of those initial steps. So just wanted to touch into those. On the next slide is a more comprehensive set of steps. If we think about partnership development as, from I don't know you to we're working together so well on step 5 that we're actually evaluating and making changes, these are sort of the steps along the path. Like, we have to know ourselves and what our purpose is. That's kind of built out in that last slide. Then we have to know our partner really well. Building the relationship takes time, and then actually actively managing the partnership. The easiest way to get this clear for you right off the bat is if we can go 1 slide further and think about partnership development in the context of human relations. So, know yourself. Before I go put an ad up on Match.com, got to take some stock. Got to, like, deal with any baggage. I have to say, am I looking to get married, or am I looking for a date to take to my high school reunion to make everybody jealous? What am I really looking for? And then you have to get to know your partner. It's kind of like dating when you're first starting these partnerships. You want to get to know people. You don't just go and just talk about yourself. You're going to have to talk in their language and get to know them. Building the relationship is a lot like setting up housekeeping. It might be really romantic and fun, but you also have to have challenging conversations like, how are we going to set up our finances and things like that. Managing the partnership is sort of like learning to live together, because you might be in love. This might be the real thing, but still maybe your partner doesn't put the toilet seat down. Like, things happen, right? And then evaluate and adapt once you're in partnerships so long term. You have to do things to keep the spark alive. You can't take partners, especially partners like this, for granted. So again, I'm just introducing these now to frame up some of what you're going to hear. So as you listen to the stories, and we're going to turn it over to Jody here in a second, and hear about these partnership processes, you might keep these stages in mind, and I believe you'll hear some of the that development process in these stories. So with that, let's hear from Jody and the story she has to tell us from Indiana. Take it away, Jody.
Hi, thank you, Karen. I am Jody Bella. I'm the Business Development Manager for Meals on Wheels of Northwest Indiana. You can go to the next slide, please. We, as Meals on Wheels, was established as a component of the VNA in '77, and because of that, we've always really thought of ourselves as already in the healthcare field. So I was brought on to just further that concept even more. We are an independent agency now, and we prepare our own food. We also do food for home delivered clients in 3 counties, congregate sites, adult daycares, children's daycares, and we actually coordinate the delivery of the home delivered meals in Lake County, Indiana. We do about over 750 of those home delivered meals in Lake County, and probably are producing right around 2,000 meals a day. So with everything else. Our partnership, probably because I come from the profit background, we were more interested in doing a lot more work on the front end and actually getting a contract with a healthcare entity rather than taking the path of doing a partnership or pilot, if you will. We actually believe strongly in the service that we offered and what we could do and how we could help to impact results for a healthcare organization. So that's the path we chose to go down instead of doing any kind of a pilot program. We contracted with our accountable care organization, and what we do is provide meals for their members for 30 days post-discharge. That partnership is for 30 continuous days, and we start those meals within 24 to 48 hours of discharge. It's for 2 meals a day. We do deliver Monday through Friday, and the weekend meals are delivered on Friday as well in a frozen format. Members who are actually what the ACO calls their clients. The member has to be diagnosed with CHF during the stay to qualify for this program. We do weekly call-ins for the ACO. They provide the questions, we make the calls. And on the days of delivery, meal delivery, we do our normal wellness safety check that our volunteers always do. We report any changes back to the ACO from condition, if you just feel someone's not doing well or anything like that, back to they weren't home or they've gone back into the hospital, etc. And the ACO does report to us if they notice that the individual has gone back into the hospital. The ACO is a payer, and this is a profit contract. So we are pretty happy that we were able to do that. Next slide. The reasons we sought a partnership, basically we wanted to diversify our revenue. We're looking long-term, creating a stable organization, and we just know that simple contracts weren't going to do it, because even though we do private pay and funded, we know that the funded is always something that is challenging, and we know that our private pay does not cover the entire cost of the meal. So for the stability of the organization, we were looking to become more of a viable player within the healthcare market with respect and partnership, if you will. We wanted to create a scenario. We find that some of our clients are hesitant to just try the program for whatever reasons that they have. And this gave us an opportunity to have individuals try the program at no expense to them. And then what we do is we convert them to private pay clients once that 30 days is over. It also allows us to show that individual, that client, how food can have an impact on their health, as well as showing that impact to the healthcare. We chose the ACO just because with the concept of the ACO being a shared savings plan, they were prepared to look at community organizations to partner with to help save those costs. We had a shared target market, so that part was easy. We spoke the same language on that. And we did have a champion who really helped us out. We had a case manager who we had done a small, simple program with a couple of years ago. And with her, we were able to make some inroads, make those connections, and we actually were able to get a contract fairly easily. Next slide. The goals of our partnership. From the ACO standpoint, they obviously wanted to reduce admissions. They wanted to improve their members' health, and they were really looking to increase the interaction with the member and the ACO coordinator. So each member has a care coordinator, and there was really no system in place for them to have great contact with that person. The members didn't actually understand what that person could do for them, what their role was, what the ACO coordinator's role was in their lives. And so we actually became a translator, if you will, for the ACO in connecting that member to their care coordinator, which then allows the ACO to really improve the care that they give to that individual. As I mentioned before, we wanted to establish that we're a respected player in the healthcare community. Most organizations understand a somewhat limited concept of what Meals on Wheels does. And I think I heard one too many times what a nice organization it was. And I knew that it was a much more than a nice organization. It was making a huge impact in the community. And we just had not communicated that well enough to the healthcare community. So that was something huge we wanted to be able to do with this contract. Today, we started as a small 6-month program, and the contract that we did is an evergreen contract, which just means if nobody stops it, it just continues. And so we started at one hospital, and I'm happy to report that the ACO has enjoyed the process so much that they are expanding to all 5 hospitals that they cover. And that also gives us an opportunity to partner with a neighboring county Meals on Wheels, LaPorte County Meals on Wheels program, to expand the program into that county, as well as give them an opportunity to add clients and continue servicing clients within LaPorte County. So we're pretty excited about where it's going. Some of the lessons learned, next slide, is patience. And I will be honest, coming from that for-profit and having developed, timeline, sales goals, those kind of things, patience was something that I needed to learn a lot in the industry. And also that change is normal. If there is one constant within the healthcare industry, I would say that change is normal. That's everything from who you're talking to and who's in charge of the program and who your champion is. It's just normal, and you just have to learn to roll with that. We had done capacity work in figuring out what we could actually provide meals-wise. We have the numbers of, of course, how many meals can we do before we need to add additional staff, et cetera. We knew technology-wise that we would need to make an investment in that, as well as in human resources in the front administration part of that. And also in terms of educating and kind of changing the culture of what we do from really client-specific to that client being the ACO, and being able to change what we do to accommodate that. Another thing was HIPAA, and I guess if somebody would have been a little more upfront about HIPAA and all the fun stuff about HIPAA in the beginning that would have been helpful. And it's expensive to do HIPAA correctly. So we also were fortunate or challenged, I guess, in both ways. We had the hospital systems information security officer volunteered their time to help us develop HIPAA. So while we know that our HIPAA plan and our methods and et cetera qualify now undoubtedly with the hospital system, it's a lot of work. It's a lot of challenge, and we were not prepared for that part of it. And I think probably Karen and everyone can speak to getting the contract was super easy. Getting the referrals is the hard part. And you saw Karen mention that earlier in a slide. We really worked hard at that, and one of the things that we realized was it's just a long education process. You're asking individuals who are already taxed in their work environment to add another step, to add another program, add another thought process, and that just doesn't change overnight. So with just what Karen was talking about, that relationship building and that continual contact, those touches, those kind of things, keeping in mind, redoing training, always reaching out to your contacts. It really does pay off for us. We're starting to see more referrals come in, and they think of us now more as a partner than just another program that they happen to run. Our most valuable lesson is that it takes time. It takes time to create these relationships. If they haven't seen you in this light and you're trying to market yourself in a different light, that's going to take some time. It takes time to change perceptions of who you are, where you are, and what you can offer. We knew that what we did was food. We do food and nutrition really well. We knew that we did that wellness check. We know that there's something special about carrying food across the threshold versus having a home health agency or a nurse come across the threshold. So we knew what our strengths were. We knew what our power was. And that was what we played on. We did not partner with anyone else. We just wanted to prove our simple, straightforward, how that could be impactful for the ACO. And that takes time. It took time for us to educate all of our staff on that. Takes time to get to the right contacts, time to research, to learn about those contacts. And it takes time to learn, especially if this is a whole new process for you. If you've never played in the healthcare field before, if you don't speak the acronym language, it takes time, and you need to make sure that you devote time to it. Looking back, I don't know that we would change anything that we did, because for us it was a method that worked. We're pretty happy to have that contract, and we actually have some things in the work where we'll be expanding on some things, so we're super happy with it. So that's where we are. I hope that helps.
Yeah, Jody, thanks so much. And the handouts, are there any of those that are from you?
There aren't. Our ACO is very specific. If I have their logo on something, I have to have their permission to share it, and okay. Did not allow for us to share that. So if someone is interested in anything along that lines, I'm more than happy to show them draft versions of what we came up with.
Look at that
and I can email those out if someone wants to contact me.
Great. So if you heard anything in Jody's presentation there that kind of rung a bell for you, write down her email here before we leave the slide. Before we turn it over to Lisa and Maureen, a couple things I would like to just point out that are themes you hear when you start talking to lots of people about partnerships. One is that their partnerships with an ACO or an accountable care organization. There's definitely a connection between willingness of healthcare to engage in these kind of partnerships and those types of organizations. They call them ACOs or sometimes MCOs, managed care organizations. These are places where there are some different kinds of financial incentives. Maybe where they will get either dinged, say if their readmissions are too high, or they might get a bonus. So we see that a lot. That type of change, Jody, that you talked about, especially since a lot of folks are consolidating in healthcare, is a really common theme. And so is the idea of having a champion or finding and kind of cultivating champions. So Jody, but before we move on, I am curious, how did you guys find those champions?
Believe it or not, our champion was a case manager who was put on bed rest when she was pregnant and called us to bring her food.
Awesome.
So we did that really well. So she became a champion because she was also a client. Yeah, and I do want to mention that change thing is really good, and you mentioned the shared savings and all of that. We have run into an instance where our ACO is saving money with our program and doing so well that the hospital, who is still on a value-based system, or a fee-based system, not a value-based system, has questioned what the ACO is doing because they're actually losing money with those clients now at the hospital level. So that's an interesting aspect that we were not prepared for either.
Yeah. And then there's a question about accountable care organizations. And I'm going to do my best here. Actually, hold on. I've got a little cheat sheet. Accountable care organizations. I have from a group here in Colorado. They have a health words little dictionary I have. Okay, accountable care organization. And I'll type this in the chat. A group of doctors, hospitals, or other healthcare providers that join together to provide coordinated care towards the goal of improving quality and lowering costs. So it's some sort of collaboration of providers that's coming together around shared goals. Many ACOs are in the Medicare public insurance program. Some of them are private, but a lot of them are Medicare. So so the makeup of an ACO may vary from state to state, but we see more and more of these types of collaborations spurred on by healthcare reform.
Yeah, Karen, and this is Mark. If I may just chime in, we have actually created a glossary with all these different acronyms that Jody is talking about and has in her slides. So we'd be very happy to include that tomorrow in the follow-up email, a link to that glossary, so you can have that when you talk to healthcare entities.
That's great. Thanks, Magda. So look for that in your email. A couple things just in terms of best practices that Jody mentioned that I'd like to call out. First, they were thinking long term. They started right with a 6-month initial contract, which, it's not a full commitment. There's an out for that partner, but they were thinking long term. They were thinking, how do we convert folks who we're helping transition into private pay clients? They were thinking, how do we use this opportunity to grow understanding and demonstrate our potential impact, maybe outside of not just to this partner, but to others. So they were thinking on multiple levels, which I'd like to call out. These are intensive strategies, and so that was a really smart approach. The other thing is, did you catch when Jody was talking about capacity and she said, we know the number of meals we could increase by before we would add staff. That's the level of understanding that I want you to be able to have around how this is going to impact your capacity. Okay, that's an indicator to me that they did a good job of that. And if you weren't on the webinar last week, I'd let you know that in the handouts from that, which I'm sure you could get from NCRNA, there's some capacity worksheets to help you think through so that you can know the impacts of capacity as well as Jody and her program does. Okay, we're going to turn it over to Lisa and Maureen and hear about their story now.
All right, folks. There we go. Oops. There we go. Okay. This is Maureen McCarthy, and I have Lisa Labonte here with myself, and we're going to talk a little bit about exploring some more partnerships and some things that we've come across since we've been partnering together for a little bit now. So I'll turn it over to Lisa to start talking about who we are.
This is Lisa Labonte, and I'm the director of the Senior Nutrition Program under New Opportunities Incorporated in Waterbury, Connecticut. And New Opportunities is a community action agency that provides a multitude of services to the community. But in the elderly services division, we have a Meals on Wheels program and congregate program. And we also have foster grandparent, senior companion, and an emergency response system, and an outreach program.
All right, and I work with care transitions, and we pretty much, the reason why this company was developed was because we had so many folks that were needing help or needing some direction, where they had a loved one that had gone to a hospital or needed some nursing home care, and then they come home and they're sort of alone and they're not sure how to set up services or what the person would need. So there was a need in the community for this care transition. So we pretty much work with folks who are being discharged from the hospital or from a nursing home and help them to coordinate care and services. It's an intensive care management program that we also would help to set up any additional services if they need, Medicaid applications done, if they needed to have any other medications or pharmacy items delivered to them rather than picked up. And then it was a natural progression to partner with Lisa with New Opportunities and Meals on Wheels, because that was another piece that folks were going to need as they were discharged home and they weren't necessarily able to care for themselves fully yet. So we manage the care providers, the physicians, the home health folks. So even if someone has home health in the home, they're also part of this program that we've been working with. And we help to manage what's going on with home health and each one of the physicians, because you would assume that the physicians are talking to each other once a patient's discharged, but they really don't. So the pulmonologist may not know what the cardiologist is doing, who may not know what the general practitioner is doing. And so coordinating all of that care and letting everybody know what was going on with each one of the patients we were working with, really brought it to another level. So, and we wanted to keep these folks in the home as long as we could, and making sure that they got optimal long-term care results from their home. So when we decided why this would be a good idea, well, the Affordable Care Act, as well as the Impact Act that came out, a few years back, really is looking at helping to coordinate care and services for Medicare and Medicaid beneficiaries. And, they wanted to reduce the costs of care, improve the outcomes, and involve the patients a little bit more in the care so that they have a voice as to what's going on. So then with Meals on Wheels, we were looking at making sure that we had a sustainable funding source so that we could provide this program. And we couldn't go back to the state, and we couldn't, we weren't able to get any federal funding. So we sort of needed another way to come about doing that. And Lisa and her team was instrumental in gaining a small grant that we utilized to get this off the ground. So we knew we were in a good position to save the hospitals, insurance companies, or whomever a lot of dollars while we were improving the care of the patients. And we know that it costs around $1,500 a day, or it might be slightly higher in your area, for inpatient care in a hospital setting, where we were really looking at keeping the cost around $1,500 per month for these folks to keep them out. So our pilot, we were lucky enough to have a really high success rate. We asked, and the cardiologist that we were working at, and we'll go into a little bit more detail about the program itself, but we were working with a cardiology group out of a local hospital, and we had the chief of cardiology that really bought into the program. Lisa and I had gone to many different hospitals, and with the grant money, I mean, it was literally free money we were trying to give away, and no one was taking the free money that we had. So this one cardiologist finally realized that, okay, I'm in. This sounds like a win-win for everyone. So he gave us the patients that he could not keep out of the hospital for more than 2 weeks at a time. And so as we're looking at these folks and bringing them into the program, assessing where their most crucial needs were. Some were diet, some were exercise, some were just oversight, but having that face-to-face with the Meals on Wheels driver on a daily basis really sort of, helped us out. So we get patients that were the most debilitated. These patients needed to be free from an institution, which is either a hospital or a nursing home, for at least 6 weeks after their event in the hospital, their cardiac event, so they can take part in Medicare's cardiac rehab program. And part of the rules to get into that program is that the patient needs to be free of an institution for 6 weeks. And the cardiology department couldn't keep these patients out of a hospital or a nursing home for more than 2 weeks. So those were the patients that we started with, and luckily enough, through the program and coordination, we were able to keep those patients out for more than 60 days. We reduced the readmission rate down to 0 for this very difficult to handle population. So we were very excited about the results that we had with the program with very difficult patients. And it's not really helpful that we have folks that don't need much help because then you can't really flesh out the importance and the quality of your program. So you don't really want to go for the easiest patients. You really want to show them that you can make this program work and show them that with the most difficult patients that they have. So when we're looking at coordinating between the practitioners and the care team members, we learned a lot there. We assumed that the physicians were talking to each other or that the care coordinators from each one of those disciplines was talking to each other, and they really aren't. We would find that the pulmonologist would decrease the medication, the cardiologist didn't know anything about it. The patient would be having symptoms based on the medication change that the other entity didn't understand. So there was a lot of care coordination to keep these folks out of the hospital. Routine follow-up with individuals and caregivers. We were in contact with these folks pretty much on a daily basis. The way we worked it up is that we had Lisa's folks on the Meals on Wheels team. The drivers would go in and they would interview the patient or ask them a few health check questions. The health check questions were set up by our team, the clinicians, based on, they were resident-centered or patient-centered questions that were asked based on the conditions that these folks had. I'm sure it's similar to Jody's program, although they were reporting back to the ACO. Lisa's drivers were reporting back to our nurses, and then we followed up with those health checks, either with the patient themselves, with the family member, with the caregiver who was in the home, or back to the physician or their group. So we would also, identify needs for the patients that maybe they hadn't had a doctor's visit in 2 weeks and no one knew what was going on. So some of the key components were those face-to-face encounters with the drivers, as well as those frequent touch points that helped keep these folks out of the hospitals. We would get involved with the health checkups to make sure that they went to their doctor's visits, scheduling additional visits or diagnostic tests. Like we had one patient who ended up having some swelling in his ankles. Some of his medications were changed. I was able to get a chest x-ray ordered at his next visit, and we were able to save the person from having to be admitted to the hospital. So those were some of the components that we really tried to pull together to improve the healthcare of these folks that we were working with. But like I said, coordinating between the different folks that were involved in this person's care, it's never just one physician. Mainly when we're working with the elderly population that Lisa and I were working with, most of them have more than one physician, and coordinating that care can be sometimes difficult. This is a copy of the hospital discharge coordination and what the drivers would ask. We actually included the full driver form. That's in your little box here on the webinar. When we're looking at the 4 handouts, this is one of the handouts that would be included in your GoToWebinar screen. So this is what the top looks like, and we would have the driver information as well as who the client was and the date. We'd ask them information about did they take their medications today, and then we would look at certain items that were appropriate to this person. Now, if they're not a diabetic and they don't have issues with blood sugar, that wouldn't be a question we would have the driver ask about. And we really thought that some of these things like weight, people might not be comfortable talking about, especially in front of a driver that they may not have a relationship with yet, but we found that that didn't happen. So the drivers were trained on this form. I went and did the training myself with Lisa and her team, and we trained all of the drivers, whether they had some clients that were included in the program or not. We were a little worried in the beginning that they might be a little fearful about doing what they were doing and getting involved in people's care needs. But we really didn't have any concerns. They really developed relationships with all the patients that they were assigned to. In many cases, it was the driver that let us know that the patient was back, trying to get back to the hospital or was heading back to the emergency room, so we can sort of head them off at the pass. And order the tests and the things that they needed to be able to keep them in the home. But that was really successful, and they really bought into it, and they developed relationships with some of these folks. And I'll let Lisa talk about that a little bit more as we move into the program. But they really did develop relationships, and they would look forward to the driver coming every day to have that face-to-face interaction. Okay, so and with the intake process here, we're looking at assessing the patient's needs or the goals. What's holding them back? What do they need to be successful? And like I mentioned before, we would hear from the cardiologist, well, this person isn't sticking to their diet, and they need a little bit more oversight. When we really interviewed and looked at it, it wasn't the diet that was the problem. The family was very strict about the diet, and they were getting the Meals on Wheels meals delivered that were appropriate for the patient that we were taking care of. It ended up being that the person wasn't getting enough exercise. He wasn't moving around. He ended up having fluid that was pooling in his lower legs, which was causing him to have to go back to the hospital. So, you end up finding out what the actual needs are, and, determining what the barriers to success are, and putting some interventions in place that could avoid that. We talk about the services that are available, what they have for home support. Some of these folks had home care in the home, and we worked with those folks. Some of them were cared for by family members, and some had no one. So we would work with whoever was in the home. For instance, if they needed an exercise program and they had a home health aide, we'd set that up with the home health aide. She would have to report back to us, how many feet the person walked, how often they participated in the program, just to make sure that they're following through with what they needed to. We looked at what they had as far as plans available for care, for follow-up, what other community services that they had coming into the home, and then as needed would supplement with whatever was available in the home. We would develop advanced care planning with them to talk about, if this should happen, what are your expectations with that end-of-life care, so that we would know what the expectation was for that person when it came to end-of-life care, should that become an issue. We also had service providers that we would set up, including transportation services, where we needed those if they needed a ride back to the doctor's office, if they needed some help with shopping. We would look for local community programs that can help them with that. And like I mentioned, Medicaid applications. If there were appeals that they needed to fill out for insurance companies, we would help them with that information. So we would provide that routine check-in with not only our nursing staff, but as well as the drivers. They started the ball rolling. They fed the information back to the clinicians. The clinicians would track the information and intervene as needed with the residents and the patients that we were working with. Okay, so the early intervention obviously was a huge key in keeping these folks out of the hospital and keeping them healthy in the community. We were able to improve the healthcare status of these folks and help them live longer lives, because again, they weren't able to stay out of the hospital for more than 2 weeks, and having them go 6 weeks or 6 weeks plus past that mark really helped them out. It helped out the physicians. They were extremely happy that the patients were able to see this level of success. It increased the patient satisfaction themselves because they were involved in more of the decision making with their healthcare, as well as they were part of the healthcare team. So it wasn't like we're talking about the patient and then we're going to tell them what we're doing. They were all involved. Their families, their caregivers were all involved in the process. And as a result, they did have safer outcomes and were able to stay in the community longer, which was, not only helpful for the hospital to reduce the rehospitalizations and save some dollars there, but also it's disruptive for the patient when they have to be admitted to that level of care, and it really disrupts what's going on in their lives as well. So I'm going to turn it over to Lisa, that's going to talk a little bit more about the head of cardiology and how we were able to get involved with this program.
Okay, so Maureen was providing the nursing oversight. Basically, our program, Senior Nutrition Services, was providing nutrition counseling through our registered dietitian. We were providing 2 meals a day, like Jody, 5 days a week, and then we would deliver the frozen meals on weekends. We also have an emergency response system that we were placing in the home for a period of 2 or 3 months. And then that daily contact with the driver was probably the most important part of the whole component, along with the nursing oversight. Those two, I think, really contributed to the success of our program. But like Maureen said, we couldn't give this away. Her and I had visited several, Waterbury Hospital, St. Mary's Hospital. We had visited them, talked to different people at every level, and we just could not get people convinced. And I think Jody was right. It's another level for them that is a lot for them to take on. And in our case, our hospitals were going through transition as well. So it was difficult to convince them to take on something like this. Then we were fortunate to get a grant from the Connecticut Community Foundation, who really believed in what we were doing. And we were able to take that money and again go out to the hospitals and talk to them. And we still had difficulty selling this program. We were fortunate enough to have a colleague that knew the head of cardiology, and he was a very innovative person in the community, had already done some innovative things in healthcare. So he was willing to take us on, and we asked him to give us some of his more difficult, like Maureen said, patients, and he did. And pretty much, it worked out quite well, and we were successful in keeping them home for the amount of time that they needed to be. We knew that the hospitals were under pressure to avoid penalties, so we thought that this was, it would be a really important program for them to take on. And fortunately, we were able to do that and show some positive outcomes.
Okay. All right. So during this partnership, obviously our goal for the hospital was to reduce readmissions and help that patient to transition from the acute level of care to the home level of care, with the intent in mind to improve the quality of if we could improve the quality of care as well as the quality of life for the folks that we were working with. And like Lisa said, the nursing oversight was a big piece of that plan of care for the patient and coordinating that plan of care. And then people would still ask us, well, the home health nurses that were out there, how come they weren't doing this? And we really couldn't answer, how come. I think everyone is siloed. They're all doing their piece, but no one coordinates all of those pieces together. And that was sorely lacking when we started this program. And it was one of the needs, I think, that helped to make us successful as well. The health checks through the drivers, like Lisa said, was a big piece of it. She got some of the dietitians to come in to do home visits, to go through the people's cabinets with them, to look at what they had in stock, to talk about their diet needs. She identified some other health issues that she brought to the nursing team that were really helpful for us. And that daily driver check, like I said, they really started to look forward to that. And they would update us on the patient's condition as well. If they sounded a little bit more short of breath today, even though they didn't, that wasn't one of the questions, that would still, come through, how they physically looked while the driver went there. In the information that we would get from the hospitals, we didn't have difficulty getting any referrals. Our difficulty was getting, the contract and getting going. Once we had those referrals, we would work with the discharge planners, and many of the departments like pulmonology would have a discharge planner or a care coordinator, and cardiology had their own care coordinator. So we would work with those folks, and so like I mentioned, so getting the patients wasn't a problem for us. But the diagnosis of the patient was really important. The multiple diagnoses or comorbid conditions that they had was important, because, you needed to know if they were, obviously they were cardiology patients, but if they also had diabetes or COPD or some other breathing issues, that would make a difference, and we would need to know that. We were maintaining the data on the clinical side and looking at those outcomes that we would share with the hospital at the end. And I think any of these programs, the most important piece is going to be the data that you're able to present back to them, because they can convert that into dollars. Even if you're not aware of the dollars with your program and how they impact the healthcare component, they will absolutely know. But that was a big piece that we were looking at as well for the success of the program. So we had 100% success with a small number of patients, but they were some of the most difficult patients that we were referred by the hospital. So we were very happy that we were able to make a difference with that population. Okay. So based on the success that we had with the hospital, they invited us to apply for another foundation grant, which Lisa is in the middle of hopefully securing for us. It's still pending at this point. And then, you know, we submitted an application with a state agency for some state as well as federal programs that we may be able to fit in with. So we're also waiting for that information to come back to see, you know, how that's going to play out. So what we've learned is that even if you're willing to give money away, and if you've got free money, it doesn't mean that folks are going to take it from you. We met with discharge planners, we met with finance folks, we met with nursing folks, and you know, securing a champion is going to be the key to getting yourself in that door, whoever that champion is. And community-based organizations or long-term care supports and services have not usually been a partner with acute care or post-acute care. But now that we're sort of collaborating, it's going to be even more important that we align ourselves together. And then, like we mentioned, they don't always take free money. But the other thing that we learned through the cardiologist is that there are some care transition codes out there that are billable to the Medicare program, but you need to go through the physician to bill those. So if they're willing to share some of that revenue, that may be another option for some folks. And then again, if you're not able to provide some of the services in your area, see if there's another champion or someone else that you can form a relationship with. Lisa and I did some, not training, but we did some introduction work, I guess, with a local hospital association, and they were really interested in what they were doing. We didn't get any funding out of that, but they were definitely interested in what we were doing. I just wanted to take a few seconds to look at the forms that we've provided you folks.
Real quick, Maureen, because we got to open it up to questions, okay?
Okay, so this form right here is just giving you the information on how important the program is and what it's sort of all about. Looking at returning home from the hospital, and it sort of explained what we were all about. We use this for when we meet with the hospital, so feel free to utilize that information. This is the full copy of one of the health check forms that the drivers were using. You can see a lot of clinical information there. And then this was the hospital referral form that usually went to Lisa's group, that they would send the information over to us for the nurses once they got this information. All right, so I'll hand it back over to you, Karen, and you can take over.
Great, thanks. I think lots of folks probably saw the same, some of the parallels that I saw. I mean, because we heard here from Maureen and Lisa, similar things we heard from Jody in terms of, what was in it for the healthcare partner, cost savings, reducing readmissions, things like that. So those are some themes to keep in mind. The theme of finding a champion. And also, I hope you heard how in both of these stories, we hear folks from nutrition programs talking about results in terms that the healthcare partners most care about. So we heard about cost savings, reducing readmissions, monitoring things beyond maybe what a driver might normally monitor. So we see some themes like that as we go. So thank you both so much. So we're going to have Magda give us questions, and I'm just going to switch to this slide. I might not go through these other slides because they're in that handout, but I just I'll reference them if they're relevant to the question. But Magda, why don't you go ahead and tell us what sorts of questions?
Absolutely. Well, there are quite a number of questions about the drivers that do these checks. Are they paid or are they volunteers? And how long does it take to ask the questions? That's for Jody. That's for Lisa, and then for Jody, the question is for the call-ins, the check-in calls, are those staff or are they volunteers? So Lisa, would you like to address this first?
Sure. Most of our meals are delivered by paid drivers. We also have volunteer drivers, but this project was primarily was with our paid drivers. It probably took them an extra 5 to 10 minutes on these questions, sometimes even a little bit longer, because they did develop relationships with these patients. And so it would take them a little, but I would say 10 minutes.
Okay. And how do they report then on what they find?
Well, if they found something right away, they would contact us and we would contact the nurse before they'd even come back, leave the home. And then once they came back, we would fax over the report to the nurse.
Okay. Good, thank you. And Jody, could you address the question on whether it's your staff or volunteers who are doing the check-in calls?
Absolutely. It is our staff, because all of our staff is trained for HIPAA. And so the questions that we're asking, we know how to protect that information, how to properly get it back to the ACO.
Mm-hmm. Okay, that's helpful. And I know there was a question about HIPAA, and I would like to propose that maybe the person who asked the question reaches out to you so you can talk more in depth about it, because that's not something you can do in two minutes. But I have another question for you, Jody. How did you start your private pay clients? And do you have the same rates for those people as the unit rate the AAAs have?
No, the AAA, the funded clients, it's actually a higher price than our private pay clients. I'm not quite sure if you're asking how the private pay program got started, or if it's a registration process question,
That was the question. How did you start your private pay clients? And then did you follow the same unit rate from AAAs or a different rate?
Okay. The private pay program was just a decision that we made. Most clients are not looking for something for free. They want to contribute to it. And this was a way that we could reach more individuals and still give them the dignity of feeling as if they're not getting a handout, which is extremely important. And then our price for that is actually $4.95, and it costs us about $7 to produce a meal. It's a little bit higher for the funded, and that's based on a contract negotiation that we do with our area agency on aging.
Okay, and there's a couple of more questions in the financial, on financials. But I would suggest that the person who asked that question reaches out to you directly. But could you talk a little bit more about how long it took Meals on Wheels of Northwest Indiana to prove the positive impact to the ACO?
At the end of actually 3 months. The ACO has seen the positive. At that point, we had 100% rate of keeping individuals out of the hospital for those 30 days. And so after 3 months, they were extremely pleased. And then at the end of the 6-month period, they were able to get that Medicare information back, because Medicare has a 3-month lag time in the data. And so they were able to kind of validate the data that we had sent them within 6 months, we were able to prove that the investment that they were making into that was paying off for them financially, and with the coordination of their individuals, their members.
Right. Okay, and then there's a question about the forms that Maureen and Lisa were talking about in their presentation. We have those for you, and we will send them around in the follow-up email tomorrow, so you can look at them. And Jody has also agreed to send the drafts of the document she was talking about to us, so we can include that in the follow-up email. So let me see. Could you, Lisa and Maureen, talk a little bit about how your contracts were structured? Were they done per interview, per visit with a client, or per patient per month, or how were they structured?
They were more structured on per patient per month. Actually, per patient for the 60-day period. So it was more than the per month component. We knew that we had these patients for at least the 6-week amount of time that we were looking to get them onto the cardiac rehab program. So that's the way that they were set up. We knew that we would be tracking for at least 60 days, if not longer, and we kept the patients in the program until the money ran out.
Right.
Okay. That's good to hear. There are a couple more questions, but given the time, I don't think we can can address those. Karen, do you have a couple of final advices, final tips for the people in the webinar?
Yeah, two things I'd like to point to, and again, these are in the handout for me. Any partnership, when you are run into some challenge, like Jody mentioned, like we weren't getting referrals quite the way we thought at first. This is a great, quick diagnostic tool to sort of say, like, what's going on here? Does my partner not know what to do? Do they not know how to do it? Do they not know why? Or do they just not want to, right? So, those providers, maybe they honestly, like, I don't know what the process is, or I don't know what this program is, or, so of course I'm not going to refer. Or they don't know how. They don't know the process. They don't know why. So then maybe you have to explain to them the role nutrition plays in, their patient not being readmitted. Or if they just don't want to, right, then you might have to go to the head of something, right? So this is a nice, quick diagnostic that can help you pick your response and your problem-solving strategy. So this is a quick piece. And the last thing I would say is it's not a process. It's a process, not a project. If you're going to enter into one of these relationships, and I think you've heard this from both Lisa Maureen and from Jody, these take a lot of time. There's a lot to learn, and it develops. And so this is not something you're going to beginning, middle, end. And we're done. We have that partnership now. I don't have to pay attention to it. Okay, this is a process, an ongoing process. So think about this as setting up a new piece of kind of like your ongoing operation, and kind of plan accordingly. That's something that as we looked and did some research in these other fields on the slide that are building similar types of partnerships with healthcare, that's what comes away from all of these fields when they're interacting with these types of systems. So I would point to that maybe in closing, and I would love to thank Jody and Lisa and Maureen for sharing the stories and for being available to answer questions and do follow up. And if any of you have any questions for me around any of these tools or things from the last webinar, please feel free to reach out to me as well. My contact information is in that handout. Thank you all so much.
I agree. Thank you all very much for attending. It is an important field to explore for senior nutrition providers and programs. It does take time. It's a new line of business. It needs to be handled in a different way, and it needs time to ramp up and to continue doing. And both Jody's program and Lisa Labanti's program have been doing it. They have continue to stay with it, and in the end that will provide long-lasting results. So thank you all very much for everything. We'll be sending you the handouts and the glossary with all the acronyms in the follow-up email, and then we hope to see you on one of our next webinars. Have a nice afternoon. Take care.